بسم الله الرحمن الرحيم. يسعدني ويشرفني طبعا ان اكون جنبي استاذنا الفاضل والاخ الاكبر والزميل العزيز. معايا ان شاء الله الدكتور سليمان غريب شير بيرسون، ويسعدني طبعا ان انا اكون اقدم اخويا برضه زميلي العزيز ودايما اللي بنحب نسمعه البروفيسور دكتور احمد شوقي فروم عين شمس يونيفرستي، ودايما طبعا احمد بيقدم برزنتيشن كلنا بيبقى اتراكتيف ان احنا نسمعها.
Thank you.
اتفضل يا دكتور.
Thank you. بسم الله الرحمن الرحيم. أولاً congratulations Professor Mohsen, the whole board of the Egyptian Hypertension Society, المؤتمر الجميل، دكتور محمد سليم، معهد القلب. Thank you so much. نغير بقى الجو شوية. ضغط 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 ضغط. تعالوا نتكلم على something else which is important in event prevention, which is choosing the antiplatelets. This is really important. Because we've seen a lot of data all over the years. احنا عارفين the number one cause of death is ischemic heart disease followed by stroke. So what is the optimization of the antiplatelets بالذات over the years؟ احنا عشنا فترة مع أساتذة العظام التكلوبيدين، بعد كده الكلوبيدوجرال، بعد كده التايكاجريلور والبراسوجرال. What's going on? This is what we're going to discuss in this lecture. These are my disclosures for this lecture, and we should know. احنا في ischemic heart disease we have two major entities, the acute and the chronic coronary syndrome. The chronic coronary syndrome is very simple, but the acute actually has improved بسبب حاجات كتير قوي, including the better intervention, including the higher dose of statins, and more importantly the P2Y12, especially the newer ones. But does this close the door for clopidogrel usage in ACS? This is what we're going to discuss. It's not. لأن احنا لو شفنا الداتا بتاع clopidogrel, we have more than 200 million patients, whether registries, whether patient presentations and prescriptions. So it's a drug that has stood a lot and still is one of the most important medications to reduce outcomes. Let's start with the acute coronary syndrome. So احنا عارفين الجايدلاينز يقول لك prasugrel, ticagrelor, prasugrel, no. Clopidogrel has a huge impact in chronic coronary syndrome and a very big one in acute coronary syndrome. Do all patients with an ST elevation MI undergo primary PCI? لا. ما زال في حتت كتيرة من العالم, including our country, they undergo fibrinolysis. And if the patient undergoes fibrinolysis for an ST elevation MI, like our patient here, we know the best is, of course, primary PCI, but this is if you have it available or the patient can be transferred within 90 to 120 minutes. طب لو هو هيتعمل له fibrinolysis, what's really important? First of all, we have to have a fibrin-specific agent. And if we're going to use the guideline recommendation, actually it's aspirin and clopidogrel are the ones which are recommended. This is the 2023 ACS guidelines. ده مش كلامي ولا كلام الناس. But this is really important. Not all ACS are the same. What if the patient has an ACS and has chronic atrial fibrillation? Does this impact طريقة العلاج في الأدوية? Of course it does. Because as much as we want protection against thromboembolism, we don't want an increase in bleeding بالذات لما نزود أدوية. We should understand to balance the thrombotic problems that we have, especially if we have multiple interventions or multi-vessel disease, and of course the bleeding associated strategy reductions, radial is better. Number two, of course, if the patient has a history of H. pylori or GERD, then we can give proton pump inhibitors liberally. And of course, we should try to avoid more and more manipulations as much as possible. لكن هنا هل ممكن أدي أي P2Y12 with aspirin the same? Actually, no. If you look at the 2023 guidelines, it is preferably clopidogrel. Why? Because the bleeding incidence is much less. And if you look at the strategy of patients with an acute coronary syndrome who have atrial fibrillation and are going to undergo triple therapy, هنا لازم aspirin. Aspirin is to be given for at least a week, maximum a month. At least a week, okay? Clopidogrel and a novel oral anticoagulant or a direct oral anticoagulant is the best strategy. وبعد السنة, then we can discontinue the P2Y12 and give a NOAC by itself. This is another area where clopidogrel is extremely important because it does not only improve outcomes, it reduces bleeding. Another scenario, ودي حالات مرات بنشوفها دلوقتي much more commoner. The older, the more fragile, the more frail, the high bleeding risk patient. ده كان patient كان مركب بيس ميكر على فكرة، وكان جاي for يعني bleeding per rectum. هو مش جاي حاجة cardiological، وهو قاعد في الأوضة جاله chest pain, ST segment changes. What are we going to do? He has an active bleeding. هنديله التايكاجريلور او براسوجرال وندخله القسطره. We went into the angiogram and you can see a bifurcation left منه اتعمل بعد كده. Very importantly from the guidelines we have 3 P2Y12 inhibitors as you see in the third row اللي هم البراسوجرال, تايكاجريلور and clopidogrel. الجديد ان هم قالوا for STEMI and non-STEMI the preloading اللي احنا بنعمله في الطوارئ او في الرعايه قبل دخول العيان القسطره وكده is not preferred. Why? There is a lot of controversy because some patients would require urgent CABG وده بيزود البليدنج. لكن نيجي بقى للحته بتاعت المريض بتاعنا ده. He has a high bleeding risk. He has a very significant coronary artery disease and a non-ST elevation MI, and we have to balance it very carefully to avoid killing our patient. Bleeding is not uncommon. على فكرة يعني nearly 40% of patients get bleeds regardless بقى هم ايه اللي بيحصل. This is really important to say, and this is from the registry by Roxana Mehran and colleagues. Bleeding increases mortality, whether in the acute or the chronic coronary syndrome, but definitely in the acute more than the chronic, and this is important. And one of the important ways to identify our patients at risk is to identify الكلمة اللي احنا بنقولها دلوقتي high bleeding risk, HBR. There are so many ways to do it, but the criteria by the ARC HBR criteria يمكن أسهلهم. criteria كتيرة قوي عشان حضراتكم تبقوا عارفين، ولكن هي الفكرة كلها it's not uncommon and it needs major and minor criteria. One major or 2 minor criteria, this patient is a high bleeding risk with possibility of bleeding which increases outcomes، يعني بتزود المورتاليتي والmorbidity والblood transfusion has its hazards too, should be weighed very quickly. وهنا got the guidelines before the 2023 actually, and they discussed a term which should not be used liberally بصراحة اللي هو de-escalation. أنا ابتديت بتايكاجريلور، أنا ابتديت ببراسوجرال، أقلل للكلوبيدوجرال which is safer, which is really important to be taken very very يعني cautiously. We need to balance the ischemic and bleeding risk زي ما حضراتكم شايفين because the thrombotic risk actually if you look at the graphs في أول 30 يوم أو أول شهر is the most. بعد كده it really goes down and the bleeding risk and starts to be more important, a little bit more important than the thrombotic risk. فهنا de-escalation, what to do, when to do it, how to do it. Don't do it if the patient has a previous stent thrombosis, multiple stents, a lot of metal inside. Do it if the patient is a high bleeding risk. Do it if the patient has simple lesions that be done. Do it, of course, if the patient is at risk of bleeding. This is really important. وبيتعمل ازاي؟ بيتعمل طبعا ان انا switch from the more potent prasugrel ticagrelor into clopidogrel as shown by the graphs. والداتا دي مش جايه من observational data. This is coming from studies, randomized control studies like the TOPIC study. دي كان كلها acute coronary syndrome. وبعد الشهر اللي هم الهاي bleeding risk they were randomized يا اما اكمل بالاسبرين and the newer P2Y12 versus aspirin clopidogrel. ايه اللي حصل؟ significant reduction in bleeding لما اعمل switching للكلوبيدوجرال، وكانت بعد شهر عشان بس ايه نقول. فthese is really important. كمان التروبيكال ACS كان الناس واخده prasugrel and they were shifted 2 weeks later into clopidogrel, and of course going with clopidogrel reduced bleeding. On the right hand side there was no hazard from increased thrombotic events. ودي حته مهمه قوي. احنا عايزين safety yes، عايزين efficacy which is very important. Again, the TALOS MI, this is clopidogrel reduction, de-escalation to clopidogrel versus continuation مع aspirin and ticagrelor. Again, a huge 45% relative risk reduction في bleeding. واحنا عرفنا bleeding as much as it is very hazardous. So you can see this extrapolated لل European guidelines in 2023 after 1 month مش قبل. unless طبعا يعني هنوقف كل حاجه بسبب يعني حاجه major. we can, in those with a high bleeding risk, de-escalate to clopidogrel in those with a high bleeding risk of acute coronary syndrome. As you can see, clopidogrel في acute coronary syndrome has a huge array of indications ومش the end of the era of clopidogrel. And of course, you do it, you de-escalate to the 75 milligrams, and it's preferred always ان انا لما اجي اعمل de-escalation to clopidogrel ابتدي بالloading dose 600 milligrams عشان برضو يشتغل a bit quicker. Chronic coronary syndrome دي برضو حتة مهمة وعايز بس اوصل لحضراتكم a little bit of concepts لان احنا عارفين the chronic coronary syndrome or the chronic coronary disease as it's depicted in the United States. احنا عارفين اي intervention فيها clopidogrel is the standard. مفيش اي نقاش. This is not a problem. And this is seen like this patient, he's old, he's having a positive stress test, underwent an LAD stenting زي ما حضراتكم شايفين. What is the recommendation? I tried to get the latest recommendation, and this is the chronic coronary disease recommendations from the United States, just published a few months ago. Definitely aspirin and clopidogrel. ما بيكتبش أي حاجة تانية. ما بيكتبش P2Y12. Aspirin, clopidogrel for 6 months. هي طبعا اتقلت من 12 شهر لأن the newer generation of the drug-eluting stents they endothelialize much quicker فبالتبعية stent thrombosis is less common. What if the patient has peripheral vascular disease? دي برضو حتة مهمة قوي. We do have patients who have polyvascular disease. If you look at data from the guidelines 2017 on the peripheral artery disease or lower limb arterial disease, clopidogrel is the preferred antiplatelet. What if the patient has a stroke, a TIA, cerebrovascular atherosclerosis? Again, if you look at the data coming from these guidelines, that clopidogrel is the one to be given in those even with aspirin intolerance. If we do a stenting, again, clopidogrel is the one. And the guidelines for stroke prevention, clopidogrel as a monotherapy or as a combination is drug of choice. فبالتبعية, we can use it anywhere, which is really important. Even ticagrelor, when compared to clopidogrel in those with peripheral arterial disease, was not superior. فبالتبعية, ليه أخد حاجة twice per day, higher bleeding risk, when I have something which has withstand the date and time and has proved efficacious with less bleeding events. آخر case عايز أشير مع حضراتكم. This is a case who's coming for a checkup. هي اتعمل لها intervention. هي كان ماشيه على dual antiplatelet therapy وجينا في فتره ال6 اشهر. هنوقف الاسبرين، هنوقف الكلوبي. حضرتك هتوقفوا ايه؟ اسبرين ولا كلوبيدوجرام؟ مش هتوقفوا حاجه؟ مش معايا؟ بعد 6 اشهر خلاص ستيبل هنوقف. لازم هنوقف حاجه. dual antiplatelet خلاص. هنوقف الكلوبيدوجرام which is the standard. اوكي. يمكن اغير راي حضراتكم شويه. طبعا the longer the duration of the dual antiplatelet therapy, the possibility of bleeding rises 2 to 3 to 4 folds, which is really very hazardous. This is really important. وبيزود cardiovascular death. ولكن اوقف الاسبرين ولا اوقف الكلوبيدوجرال؟ ده سؤال. Number one, why were people stopping clopidogrel? Because aspirin was cheaper. بس. What is the data we have for aspirin? We have data, but not a lot. يمكن بعد new data دي هغير رأيكم. Aspirin is good, but aspirin has a problem. The bleeding risk, especially the GIT. The data from the novel drugs وقلة bleeding اللي عندهم as compared to aspirin, especially in GIT bleeding, is important. جت study اسمها الهوست exam. دي randomized control study. نكمل clopidogrel ولا نكمل aspirin post PCI for a follow-up of up to a year and a half. What happened? There were more than 5,000 patients randomized into 2 arms بعد 6 أشهر اللي هو خلاص dual antiplatelet therapy, and then we're going to randomize to either clopidogrel monotherapy versus those in the other arm aspirin monotherapy. There was a significant reduction in bleeding في clopidogrel arm. This is important, mainly driven على فكرة major bleeding و mainly driven by GIT bleeding, which is really important. We want a good efficacious drug. We don't want complications. This is really important. And this was followed up for a year and a half. يعني كمان 6 أشهر. يعني they were followed up for 2 years. مش بس كده, just recently published the host exam, which was extended up to 6 years تقريبا, just under 6 years. And again, the data was better in the clopidogrel arm بالذات لما بنتكلم على البليدنج. all cause death, non-fatal MI, stroke, readmission for an acute coronary syndrome and the major bleeding combined كانوا أحسن في clopidogrel arm بالذات حتة البليدنج which was really important. فبالتبعية the study concluded that clopidogrel monotherapy as compared significantly reduced these endpoints. It's not just as good as, it is better when it comes also to bleeding. ما كانش في فرق في المورتاليتي عشان برضو we have to be honest. So when you prolong medications, this is not our case, you actually have 4 options according to the guidelines. ممكن prolong في الناس اللي عندهم high thrombotic risk بclopidogrel, بأسبرين. ممكن prolong by prasugrel مع aspirin, which is a little bit scary for me. Lower dose ticagrelor, والوحيد بس الانتي thrombotic the low dose of rivaroxaban 2.5 twice per day. لكن definitely you should weigh the bleeding and the thrombotic risk. آخر حاجة برضو عشان تبقوا حضراتكم عارفين, this is a sponsored lecture, yes, but we have to understand the situation. The situation is, are all medications the same? No, this is really important. We know the data is mainly driven by the brand, but does generics that we have withstand time, have proved themselves? ده سؤال مهم قوي. أنا لما أكتب حاجة as serious as clopidogrel في حالة هيحصل فيها thrombosis أو bleeding, I have to understand. And this is where Eipico really has a different edge عن الآخرين. Their clopidogrel thrombo was not just a medication that was shown bioequivalence. لا, ده اتعمل bioequivalence in a very important study that was published in the Internal Journal of Clinical Pharmacology in 2009, and it showed a no significant difference between it and the brand clopidogrel. فit was not just something done في معامل وزارة الصحة أو معامل, مع كامل احترامي طبعا لمعامل وزارة الصحة و everything, but it was done in a very controlled environment by a third party that showed a significant efficacy and safety as that of the brand clopidogrel. وهنا الجورنال لو حد عايز بس ياخد quotations, فدي ما فيهاش مشكلة. And this is where really a good generic becomes a brand-like medication, طبعا مع فرق السعر الكبير جدا. تمام؟ فmy take-home messages, clopidogrel definitely في chronic coronary syndrome ما فيش مشاكل. Can it be substitute to aspirin? على فكرة من 2014 neurological guidelines بتقول كده في stroke guidelines. For coronaries الهوست والهوست exam. In acute coronary syndromes احنا دخلنا في الإيرا بتاعت البراسوجرال تايكاجرون. طبعا البراسوجرال مش موجود في مصر إلا كان في بعض الستاديز اللي كان بتتم. Definitely clopidogrel still has a huge role in acute coronary syndromes in certain indications. It is as good as and can be de-escalated بعد شهر مش قبل كده, عشان this is really wrong if we do it and it's against all studies and guidelines. So use your medications wisely and hopefully patients will get better. Thank you so much.
شكرا دكتور أحمد. مفيش حد عايز يسأل. شكرا دكتور أحمد.
شكرا يا بيه.